I want to thank the FSH Society for inviting me to speak today. I've had an opportunity to go to some of the research meetings, but this is the first time I've come to the patient information meeting. And I'm really delighted to be here because, as a physical therapist, I learned so much from interacting with patients. And even though we've serially seen patients in clinic or in research, when I'm with 200 people and watching all the equipment and how they move and how they function, it's a truly learning experience for me. So I'm really, really thankful for being here. Can I ask how many of you have participated in research studies with Rochester? Can I have a show of hands? So there's a fair number of you, and I really want to thank you for your participation. How many of you are registered with our registry? Again, a fair number of you, and thank you so much because we really learned from that. And for those that have participated with us in research and participated in the registry, you know that really in Rochester we have an amazing team. And I did not put a slide in to acknowledge the people that I work with, so I'm going to do it now before I forget. I really want to acknowledge Dr. Griggs, who was the chair and the head of the unit when I was hired in 1980 at the University of Rochester. And since then, Dr. Moxley, Dr. Thornton, Dr. Tavell, all the people that I work with. And we have a wonderful multidisciplinary team in the clinic also with nurse practitioners, pulmonologists, respiratory therapists. And really, so what I bring to you is really what I have learned over the years from you and from the members of both research and clinical that I have worked with. So as was mentioned, actually the society funded work on this guide that was written with my colleague Wendy King at Ohio State University. And the reason we wrote this was, as part of our research, we would get patients from all over the country in the 1990s, and everyone said to us, it's so hard to find a therapist who knows about FSH. They look at our shoulder problems and they treat us like orthopedic patients who had shoulder surgery, and they don't appreciate that FSH is different. And I appreciate that concern, but I also need you to understand that FSH is a very rare disorder, okay? To us all, it seems so common, but really, if you think of its incidence compared to, say, stroke or multiple sclerosis or other things, it's a very rare disorder. So it's not unusual for your neurologist or your physical therapist that you are the first and only person with FSH that they will ever meet and see and work with. And it's important that we educate each other. You bring an amazing amount of knowledge about your condition that you can bring to your provider. And even though you may have a provider who's never seen a patient with your condition, as long as they are willing to learn and work with you, that I think is the most important characteristic that you're looking for in the people that you work with. And one of the reasons we wrote this booklet, and if you looked at it, it was written both for the patient and the therapist. And we wanted both to understand what is the purpose, what is the condition, how should we deal with it, how do we work together. So even though this was published in 2007, I would encourage you, please, to take a look at it and share it with your providers if this is your first encounter with a physical therapist. So let me ask you, how many of you have worked with a physical therapist? Again, a fair number. How many of you have worked with a physical medicine and rehab specialist? Fewer, okay. And how many of you have asked about exercise and maybe not encouraged because of concerns that it might do harm? How many of you have had that experience? And that's not unusual. In fact, I would say that, until almost 5-7 years ago, we were all very concerned about exercise and the impact of exercise. And as you know, the first dictum of medicine is do no harm. And since we didn't know enough about what causes FSH, would we do harm by exercising? People tended not to support exercise in this population. Also, as was mentioned before, FSH is one condition where there's a lot of asymmetry, and the literature seemed to suggest that if you were right-handed, your right side seemed to be more affected. And the concern was, is there overuse here? And that was another reason, we worried that maybe we don't want to suggest doing too much strenuous stuff. But the thinking over the last decade has changed, and the reason it has changed is more and more small studies have appeared in the literature that show that moderate level of activity and exercise seems to do no harm, as Dr. Matthews mentioned in her talk, and that it may actually be beneficial. And so I think we have all gotten more comfortable in talking about exercise and prescribing exercise. So my goals for the presentation today are to discuss the pertinent information from the guide, and then, since the guide was written in 2007, provide an update on exercise and activity. And the two other topics that have really come to the fore is the issue of pain and fatigue in this condition, which really we didn't know how common it was and how much of an issue it was. And then talk briefly about the recommendations from the ENMC International Workshop that occurred in 2010 that, again, Dr. Matthews talked about. And in this workshop, where there was evidence on certain things, of course, our recommendations were evidence-based, but there are a lot of areas where there is really not enough evidence, and there the group came together and worked on a consensus to make recommendations about how we should proceed while we still wait for the evidence to build. So in general, what are the goals of physical therapy? Really, they are the four that are on your handout. Maintain optimum health, prevent and delay secondary complications, maximize functional abilities, and improve or maintain quality of life. Now, this requires individualized plans based on individual needs, because as you look across the room, each one of you is at a different stage. Each one of you has different needs. So even though we can make some general recommendations really to give you the maximum benefit from a physical therapy consult and physical therapy guidance, we really need to get to know you, your needs, and what might be the best set of recommendations for you. And the plan then, depending on the stage of the disease that you're at, might just include recommendations regarding appropriate exercises and activities. Someone's that newly diagnosed and wants to know, what can I do to maybe delay some of the secondary problems? We might work with you on activities and exercises. If pain and or fatigue are a major issue, we might work on, how we might alleviate that for you. And then as the disease progresses and it affects your mobility, we might work with you on orthotics, mobility devices, modifications in the home, etc., so that you can continue still to function at your optimum. Now, in our clinic and in general, I personally take a very holistic view of health, if you will, and I take the WHO definition of health, which was actually, this is a definition that was adopted in 1946, even before I was born. Health is a state of complete physical, mental, and social well-being. It's not just about the physical, and not merely the absence of disease or infirmity. And that's why when I said, when we want to optimize health, we are not only interested in the physical dimension, but also the mental and social dimension. We want to make sure that you're doing well in your daily life, in your recreational activities, things that make you tick. You know, we all have that. And so we really want to try and work on all aspects and how we might help you, given the limitations that this disease has imposed on you. Now, we all know that physical activity has a great impact on health, and this actually comes from a website that I've listed in your references, from the physical activity guidelines that were published by the CDC in 2008. We know that physical activity helps control your weight, reduces risk of cardiovascular disease, diabetes, some cancers, strengthens bones and muscles, improves your mental health and mood, improves your ability to do daily activities, and increases your chance of maybe living longer. Because if we can delay the cardiovascular diseases, diabetes, and other things, obviously we are going to do better general health-wise, and this will impact longevity. I would urge you to really look, even if you just type in physical activity guidelines on Google, it'll bring you to this website. And even though we complain about government sometimes, this site does a great job with what the government has done, giving recommendations about exercise. It's for pediatrics, adults, older people, people with disabilities. I mean, there are amazing videos on it, all kinds of things that can help you guide and tailor a program for yourself. So please take a look at that website. Now, what do the recommendations say? The recommendations say that we need aerobic activity, and they recommend 2 hours and 30 minutes, which is about 150 minutes of moderate intensity aerobic activity every week. So let's break it out. That means 150, okay, 5 days a week, so that means 30-minute sessions on a daily basis. We have gotten into this mindset where we think about exercise and activity that's something we need to do in a special place at a special time with special clothes. That is not true, okay? Physical activity and exercise needs to be built in our daily life. And you know, that special place, special time, special clothes is how we thought about it through the 80s and the 90s, but we've really changed our thinking about it now. And really what these guidelines suggest is you can break it up into smaller chunks during the day. Even 10 minutes at a time is helpful. So think about it. We do this. We might do this walking. I mean, how many times have I seen someone circle the parking lot twice to find the closest parking space, then come out in their gym clothes and go to the store? And I'm thinking, why? Find the farthest space. Walk 10 minutes to the store. But that's what happens. So how can we build in activity and exercise in our daily routines? Well, we do it all the time. Part of the daily chores. You know, raking, mowing. For those of us who live in the Northeast, shoveling snow. Line dancing, fun activity. So what is moderate intensity activity? A simple explanation is something you can do while you still have a conversation, so that you're not so out of breath that you cannot carry on a conversation with someone that you're doing it with. And I would highly recommend that, you know, you find partners to do this with. It becomes much easier when you have someone to do it with, when you can talk about things, when it becomes a social activity rather than an individual activity that you have to do, okay? What about strengthening exercises? The guidelines recommend that we need to do 2 or more days a week of muscle strengthening activity that involves all the major muscle groups. So the large muscles of the legs, hips, abdomen, back, shoulders, etc. Now we all know that, you know, there's a huge issue with the shoulder girdle and the abdominal muscles in this condition, and it may be difficult for many of you to do these. Also, there is a certain amount of concern with strengthening exercises, especially for the weakened muscles. So what I use as a guide is if you cannot move the body part against gravity, i.e., lifting my arm up. If you cannot do that, and that's when we test muscles, that's what we call a grade 3, okay? On a scale of 0 to 5. That's a grade 3, 5 is normal, 4 is where you can move it against gravity and take a certain amount of resistance. If you are unable to move, if the muscle is not grade 3 or above, most probably your daily activities and the strain that you're putting, just getting that done, is more than enough. And you do not want to tax that muscle any further with resistance or strengthening exercise. Okay, so that's the general principle that we stick with. And again, individual patients need individual guidance from individual providers. So what are the current recommendations for individuals with FSH? We recommend that you get a certain amount of aerobic exercise, cardiovascular activity. For muscles that can take it, a certain amount of strengthening activity. Now, what do we need to do for muscles that are grade 2 and you cannot move the body parts against gravity? Now, think about it, and I'll take the shoulder girdle as an example. We know that one of the big issues is the inability to raise the arms overhead. All joints need a certain amount of oiling, if you will, and movement. And for those that cannot use or move the joints through the full range of motion as part of their daily activities, it's essential that we find alternate positions for you so that you can still take the limbs through the full range of motion. So if I have a patient that cannot lift their arm up against gravity, okay, what I might say to them is, try and lay down in bed, okay, and see if you can, laying, do this. Okay, you eliminated gravity. You're not working against gravity, so it's gravity minimized, but you might be surprised that you can't do the standing up. But laying in bed, you can do that. Or if you can't lift it up forward, I might suggest to you, lay on your side and try and do this. Still get the full range of motion for your arms. So where weakness is an issue and muscles are less than grade 3, we might recommend alternate position, gravity minimized position, so that you can still move the body parts through full range of motion daily. Now, why do we recommend this? Because it feels nice to move. Okay, otherwise we get stiff, and it's a vicious cycle. You don't move, you get stiff, you then try to move it, it hurts, you get into the cycle of pain and disuse. And so not only do we have a concern about not overdoing it so that we don't hurt you, but then on the other side is the concern of disuse. Because disuse can lead to atrophy and weakness also. Think about it. If any of us had a fracture and we had our leg in the cast and we didn't use it for a couple of weeks, we know that there's going to be muscle atrophy and weakness. And that's what we call disuse atrophy. And as Dr. Matthews mentioned this morning, it's a fine balance between enough activity, overactivity, and not enough activity. And for each person, it's hard to find that balance. People will say to me, so how much do you recommend that I do on a daily basis? And I say to them, I can give you these general guidelines, but what you do on a daily basis, only you are the judge of that. And if you remember our speaker yesterday and many today, in fact, one of our panelists here said, learn to read your body. Learn to hear the signals that your body sends and work within the parameters of that. If you're a parent with a young child that you've been carrying around today, a lot because you went to the zoo, I'm not going to say to you, you need to do extra strengthening or aerobic activity today. Or you're a parent who went to the mall with your teenage daughter and you did enough walking. I'm not going to say to you, no, you didn't do your exercise today. So you really need to judge how much you're doing based on your daily activities based on your role and responsibilities as part of the family, and yet how do you remain active enough so that you do enough for your well-being. So even though we can give you some general guidelines about what is recommended for aerobic activity, strengthening activity, flexibility, and range of motion, really the thing we have tried to live by in our clinic, irrespective of the diagnosis, you are a person first, you are a child first, you have that condition next. Okay, you are a person with that condition, step 2. So you really have to look at, as a human being, as a person, as a parent, as a child, as a friend, what it is that you want to do, and really try and live your life that way. Also, how, you could do some of this as part of your recreational activities, and that would be even greater. I was so excited to hear about all the hiking in the Alps. That's wonderful. That's exercise, fun, social component. That's what we need. That's what we want. The only other thing I would add, and again, I have patients that say, yes, they like it, they don't like it, yes, it's good, it's difficult, they don't like the chore of, changing, not changing, getting in and out of the pool, availability of a pool, easily available. But if you can, exercise in the water is good. Especially a warm pool relaxes you. Water can work as resistance, or the buoyancy can help you move body parts that you can't. I work a lot with kids with Duchenne dystrophy, patients with myotonic dystrophy, FSH dystrophy, and patients who are in a wheelchair at a certain point still may be able to get into a pool and walk. And that feels like so much freedom and wonderful. So again, based on your individual preferences, this is an option that you may want to consider, and we highly recommend. So what is the evidence for recommendations in FSH? The aerobic training recommendations come from studies by Orngreen. CUP looked at a lot of studies, and their criteria were not as strict as the Cochrane review that I've described later, and they felt that, there is level 2 evidence that strengthening exercise in combination with aerobic exercise are likely to be effective for muscle disorders. And then the Cochrane review, which uses very strict criteria in what studies they will accept and not accept, basically said that moderate intensity strength training appears not to do harm, but there is insufficient evidence. And one of the problems, you've heard a lot about clinical trials and randomized controlled trials and placebo-controlled trials. You can give a dummy pill. How do you do a dummy exercise? So it's very hard to do randomized controlled trials. And so there is almost very little class 1 evidence, which is what you want, because class 1 evidence is based on randomized placebo-controlled trials with exercise trials or any kind of rehab trials, actually, whether it's equipment or exercise. So unfortunately, it's going to be very, very hard to have large randomized controlled trials, level 1 evidence for exercise and rehab therapies. And so we have to go by what we learn from maybe lower quality trials, registry data, large cohort studies, etc. But those are helpful. As I said before, each one of you is at a different stage. And when you talk to a therapist, the things that they might take into consideration is what is the age of this person. Is it a child? Is it an adult? The interests will be different. Things that they want to do and the reason they want to do the exercise or activity is different. Maybe the younger people want to do it so that they can be more with their peers and doing stuff that they want to do with their peers. We need to take into the consideration the current clinical status, the clinical profile, what muscles are affected, what are your abilities, what are your difficulties, and then the personal profile. What is your role? I mean, are you working full-time? Are you retired? Do you have a desk job? Do you have a physical job? What's your role in the family? Do you have young children that you're dealing with? What are your interests? What are your financial considerations? Environmental barriers. Not a pool nearby. I have to go half a mile to get to a pool. Well, maybe that's not a good idea then to recommend pool therapy. So all these issues have to be taken into consideration. And I think this is where you and your healthcare provider need to work as a team to arrive at solutions that will work for you. So how do we go about implementing recommendations? You need an evaluation by a healthcare provider. And when I say healthcare provider, I'm not necessarily saying it has to be a physical therapist, even though I would prefer that. It can be anyone. It can be your primary care provider, your neuromuscular specialist, your rehab specialist, someone who knows you, someone who knows your disorder, and someone who's willing to work with you on a long-term basis to give you the guidance. Based on their evaluation, there'll be recommendations. And not only does there need to be evaluation and recommendation, but really there needs to be a certain amount of monitoring and adjustments. As Dr. Matthews again mentioned, if something hurts, you need to know that. You need to let them know that, the person who's supervising you or working with you. And I cannot emphasize enough the last part, and that's self-monitoring, because you are the final judge, really, of what you can do or cannot do, or have you do it, how frequently you do it, in what way you do it. So you really have to take an active role in your own management and work with your providers. Now, as has been said before, pain and fatigue are two things that have gotten a little more attention in the last decade. And depending on the report that you read, 50 to 85% of patients report pain. And the most common sites include the shoulder girdle, the low back, and the legs. And that's not surprising, given that, that's where the weakness starts. Those are the parts that are most affected. And we know that pain can affect quality of life. And as was said before, there are reports of medications, heat, massage, etc. Everything has been used, and there are no controlled trials to really say this is better than the other for management of pain. So very often, again, it's a trial and error thing. You may want to keep a log of, what activities or amount of time spent in an activity creates problem. How do you build in appropriate rest periods for your muscles to have a chance to recoup and start working again? So again, as I said before, self-monitoring and working on these. I know it can sound a little frustrating that we cannot tell you, oh, take this pill and you will be good forever. Unfortunately, we are not magicians. And all we can do is work with you in trying to help you as best as we can in managing these symptoms. Kathy showed this slide. Abdominal weakness is something that, even though we talk about facioscapulohumeral, actually it's the abdominal weakness that is a very, very early and prominent feature. And this abdominal weakness then creates strain on the back muscles. Okay, because really to keep ourselves erect, we need good strength on both sides, front and back. And if the front is not doing its portion, then that causes an extra strain on the back. And that's why very often the problems with back pain in this condition. And so we do recommend an abdominal support. And again, as Dr. Matthews said, it may be easier when you're sitting down. As the strength declines, your body finds all kinds of adaptations to move. I mean, I am always amazed when I'm done testing a person on the table, and then they get up and walk. And I think, how the heck are they doing this? But it's amazing that because this is a slowly progressive condition, how nicely, the body just gradually adapts to that increasing weakness, and we still continue to function. But under those circumstances, you add one little new thing, and it can throw you off completely. So when you try and use an abdominal corset, when you're just hanging by a thread in terms of your walking, it can throw you off, because now suddenly your body mechanics has changed completely, and you have to adapt completely to this new thing that you're wearing. And so maybe it doesn't work when you're standing and walking in that limited amount of walking, but maybe you can continue to use it when you're sitting to give the muscles a rest so that they are not constantly trying to hold you in the correct position. One slide I didn't add was also about the neck weakness. If you find that your neck gets tired, maybe a soft cervical collar might be helpful, again, to give the muscles the rest that they need and this external support. Another concern is if there's extreme neck weakness, then there's concern that when you're traveling in a car, sudden stops can create a back whiplash kind of effect. So really, even as a protective mechanism, using a neck collar in some of our very, very weak patients is something that we would recommend. Now, we've talked about fatigue, and the 60% number comes from a study in the Netherlands. And what they found was fatigue was related to the age and impairment. So, someone that was affected earlier, fatigue seems to be a major issue for those folks. And it was interesting for me to hear from the panel member that, one of their issues was actually fatigue, that people didn't recognize. And then the more the impairment, more the weakness, obviously there's more fatigue. And the folks in Netherlands have done a great job of trying to tease out, is this physiological fatigue, experience fatigue, etc. And their thinking is, based on, again, these studies with nerve stimulation, etc., that this is what they call the experienced fatigue and not so much the physiological fatigue. And so then to deal with this experienced fatigue, we really need to work on energy conservation strategies. And what is the appropriate amount of rest and functioning to try and minimize the fatigue. What I say to folks, it's essential that you save your energies for the things you really want to do. And if that means using a mobility device for, long distances, do it. Save your energy for the short distances in the home. So again, use your energies wisely and appropriately for things you really need to do, want to do, etc. And don't hesitate from, using whatever mobility device helps you and helps you function at your optimum. I'm just going to touch very briefly on the AFOs. I know we started a little late. We are running out of time, and the next speaker needs time. There are so many different kinds and so many options, and what is best. I will say this not only about AFOs, but assistive devices and all kinds of equipment is really the factors to consider are the picture of strength. Is it just the tibialis anterior that's weak, or is there also quadriceps weakness? So the total picture of weakness and how it's affecting your function will decide the appropriate orthotics or devices. How much of caregiver assistance is available and needed? What's the environment in which you're going to use the device? And cost, it's wonderful to have motorized devices, but they're heavy. They can't just be thrown in the trunk of the car. It requires a van. That's an added expense. So all these issues need to be taken into consideration when making these decisions. So the key is find a provider that you can work with and be a team in managing this disorder and the lifelong needs that you will have. Thank you so much for giving me this opportunity.